everybody, Dr. Ryan here. I'm a board certified specialist internist. Thank you so much for joining us in this our 74th OSCE series episode. We are tackling urticarial vasculitis. I strongly encourage you to subscribe to my channel. If you haven't done so, thank you so much. Okay, so we've got a middle-aged woman today who presents to you with chronic daily hives lasting for more than 24 hours. Not beehives now, urticarial hives. Okay, the hives are described as burning and painful rather than pruritic. Okay, and it's associated with joint pain and swelling, malaise, fatigue, and weight loss, and associated purpura and ecchymoses, as seen here, purpura and ecchymoses, right? So what do you think is the diagnosis? So she's middle-aged, chronic daily hives lasting more than 24 hours. It's not pruritic, it's rather painful and burning, associated with joint pain and swelling. There's constitutional symptoms and associated purpura and ecchymoses as shown. So this, my friends, is what we call urticarial vasculitis. It's very important to distinguish urticarial vasculitis from chronic idiopathic urticaria. These are two different entities. In urticarial vasculitis, there's, as the name implies, inflammation of the underlying vessels. And patients report hives lasting for a longer duration of time, generally longer than 24 hours, in a very fixed, precise location. In contrast, chronic urticaria, the hives are very short-lived, probably minutes to hours, and they are migratory to different sites. Often patients describe the hives in the setting of urticarial vasculitis as being burning and painful versus being just pruritic and itchy in chronic idiopathic urticaria. Now, other red flags that can help us to distinguish urticarial vasculitis are that you have residual hyperpigmentation, the presence of purpura and ecchymoses, petechiae, arthritis and arthralgia, as in the case, and of course constitutional symptoms of fatigue, malaise, and weight loss. So the diagnosis here, my friends, is urticarial vasculitis. We place the diagnosis on skin biopsy. Occasionally, if you do blood work, you can see that they have diminished complement levels, decreased C3 and C4. How do you address this? With immunosuppression, right? The key drugs we use, methotrexate, azathioprine, cyclosporine. So this is looking at the basic pathology of urticaria, not necessarily urticarial vasculitis, but urticaria. This is a beautiful slide taken from the good folks of the Calgary Guide. I recommend you check out this website. Beautiful resources there. So the first certification point in terms of the pathogenesis and clinical findings is distinguishing immunological urticaria from non-immunological urticaria. So by immunological, we're implying it's immunoglobulin E dependent, and that gives rise to a type 1 hypersensitivity reaction, whereby the allergen binds to immunoglobulin E receptors on the mast cell or the basophil surface, right? Versus non-immune, which is non-IgE dependent, and that depends on other stimuli, like direct toxin stimulation, but non-steroidals, for instance, or emotional stressors, or physical stimuli, like aquagenic pruritus, and activation of membrane receptors involved in innate immunity. And these give rise to activation of specific receptors without prior or previous sensitization. So the net result of this would be activation and degranulation of mast cells, which then induces some kind of inflammatory response, the subsequent release of histamine, as well as our inflammatory mediators of tumor necrosis factor alpha, serotonin, proteases, and proteoglycans. And these serve many purposes. First of all, binding of the H1 receptors on smooth muscle cells, endothelial cells, and neurons, and that gives rise to the so-called triple response of Lewis, with vasodilatation, which then leads to local erythema, vasopermeability, which leads to the hives and the wheals, and axon reflex in the CNS give rise to pruritus. There's also binding of the H1 and H4 receptors on the peripheral T nerve fibers, which contributes to the axonal reflex in the CNS, and binding of the H2 receptors results in vasodilatation and local erythema. Please note that acute urticaria is of new onset, generally less than 6 weeks duration, and accounts for 70% of urticaria we see clinically. It's self-limited, versus chronic urticaria, which tends to be recurrent, greater than 6 weeks duration, and accounts for about 30% of the urticaria we see clinically. My friends, the book of John chapter 4 verse 24 says, "Behold, a time is coming and even is now here." It's coming and it's now here, when the true worshippers will worship the Father in spirit and in truth. These are the kind of worshippers the Father seeks. So when we look at the tabernacle, right, there was the outer court, the holy place, and the most holy place, which is representative of man, body, soul, and spirit. Now, our soul is made up of our mind, our intellect, and our will. But when Jesus Christ died on the cross, the curtain that separated the most holy place from the holy place was ripped in two, which means that now we are able to commune with God in the spirit. We're moving from the soul into the spirit, from the holy place to the most holy place. And the evidence that you are in the spirit is that worship before God becomes a sacrifice, it becomes a lifestyle, and it changes your will so that we crucify the flesh man and surrender to God's will in our spirit. And thereby, we can do God's will. These are my references. Have yourself a lovely day.